Welcome back to Fine Lines. I am Suzie Carroll. I am one of the founders of the Fitz, and today I am sitting down with Dr. Paul Phelps, one of the most sought-after oculoplastic surgeons in the Chicagoland area. So welcome.
Thanks for having me.
Thanks for sitting down with me. This is exciting.
Yeah, I'm excited too.
This is our first time meeting officially in person, though we have interacted through the gram many a time.
Right. I feel like I know you already.
Do you?
Yeah.
That's great. I'm pretty much who I am online and in person, or at least I try to be. But today I wanted to bring you in because as I was thinking about who to bring on the pod next, I wanted to talk to someone who I collaborate with and bridge the gap between the surgical and non-surgical sides of aesthetics. And you do just that. So you're an oculoplastic surgeon.
Yeah.
What does that mean? And what is your training?
Great question. So oculoplastic surgeon basically means you did a residency in ophthalmology. So you were doing like eyelid lacerations in the emergency room, but you're also repairing eyeballs in the emergency room and doing everything like eye related. And once you graduate, you could, be a comprehensive ophthalmologist. I went on and did a year of training in Madison, Wisconsin on ophthalmic pathology. So like looking at eyeballs under the microscope and doing a bunch of research. And then I did a 2-year fellowship after that on oculofacial plastic surgery. During that fellowship, we only did like eyelid surgery, brow lift surgery, mid-face, facelift kind of surgery. And so during that fellowship, it was all like facial plastic surgery,
basically.
It's
all about the eyes?
It's all about the eyes, yeah. All about the eyes.
And so when we're talking about the eyelids, I told you, I'll tell everyone, I got a bleph when I was 34 years old. Now, you didn't know me when I was 34 years old, but a lot of patients are asking, when is the right time to get a bleph? How early is too early? Do you need a revision down the line? What do you tell your patients?
What do I tell those patients?
Yeah.
I'd say it's a good question. And the time to do it is when the benefits outweigh the risks. And the benefits outweigh the risks when it's something that's constantly bothering you, when it's something that, you have enough excess skin that can be removed safely without causing, a bigger problem like lagophthalmos, which means you can't close your eye all the way. If there's only a few millimeters of extra skin there that I could remove, you may not see much like bang for your buck. The other thing is, I don't think the age is as important as the anatomy. Because when I look at the age, like I've had patients who were, 18 who had dermatochalasis that was so bad that was affecting their vision. And back when I used to be working with insurance companies, we would get patients approved for visually obstructing, dermatochalasis in like people as young as 18. And in patients with like ptosis or droopy eyelids, I mean, we could do a ptosis or droopy eyelid surgery on someone who's like 8 years old, That said, when's a good time for most of your or my population? I usually say it's, right in that range of like 35 to 55 or so. The thing about when you're younger is you heal faster. You get to enjoy it for longer.
I tell my patients that all the time. Do it now so you can enjoy it.
So you can enjoy it, yeah. So, if it's something you think about every day and you do it, guess what? You're going to enjoy it every day instead of, being bothered by it every day. On the other hand, if you wait until, Medicare pays for it when you're 65, 70 years old, the negative part of that is you also don't heal as well. It takes longer to heal. It's a more dramatic difference generally. And how long are you really going to enjoy that improvement in your vision?
I did it because I believe one of my favorite features on my face is my blue eyes. I get them from my mother, very blue eyes.
You have beautiful blue eyes.
Oh, thank you. Thanks, Dr. Phelps. I love my blue eyes, and they're part of my identity as much as my red hair is. But I get my blue eyes from my mom, but I get my eyelids from my dad. And my dad, almost all of my life, my dad would do this at the end of the night. He would hold his eyelids up like manually and just like, he gets so, they'd get so heavy, and he would always talk about his eyelids. And so as I was looking at him and growing up, in my 30s, I was saying to myself, I don't necessarily want to feel that way like my dad did forever, always saying, I wish I could do something. I wish I could do something. So I just took it into my own hands, or my surgeon's hands,
right,
and just got rid of it. And it's been, I love my eyes again. I feel brighter. I feel like I look more like myself. My pictures and how I present is now matching what I've always thought that I looked like.
Yeah.
If that makes
That's
sense.
Great.
You know?
Right.
And so,
in other words, living your best life.
Yes, I'm living my best life in my best skin, in my era. I don't know. Hey, Fitzers, are you enjoying this podcast? If you come in and you mention Fine Lines at checkout, you'll get $50 off for new patients and $25 off for returning patients. For additional information, check out the show notes below. Why do you think, there's been such a boom of blepharoplasties, upper, lower, brow lifts as well, within the last 5-6 years. You definitely went into the right field.
Thanks.
Why do you think there's been such an uptick in the discussion about this type of plastic surgery?
I think it's multifactorial, but before I get into it that a lot, I want to comment on what you said, which is that I saw where this was going with my mom and dad. That is one of the most common things people say to me. They say, I see what my dad looks like now, and Medicare could cover his blepharoplasty. It's so bad he can't see. I want to do it before it gets so bad that, I'm getting hit by a bus or something. I want to do it at a time where I'm going to see a benefit to it that's also cosmetic in nature.
Yeah.
And makes me feel confident and helps people see my eyes.
Right.
So I think, generations before us, a lot of them would kind of tolerate things for longer because there were other factors holding them back.
Stigma,
for example. Yeah. But why are so many people getting it now?
Before you go there.
Yeah.
I agree.
Yeah.
And actually, right after I got mine done, my dad went and got his done.
Nice.
So it was great. And
he was happy, right?
He's been really happy. He works in sales. And in sales, again, it goes back to that human connection piece, right? It's you need to A, feel confident, but B, connecting with someone is always through those eyes, right? Kind of making the eye contact, showing expression, and I think it's been really a great thing for him, and he agrees, and so yeah,
great, that happens a lot too.
Yeah.
I have oftentimes patients who come in and say for example, my sister could really use this more than I could, but I'm going to get it first just to show her how easy it is. And then the sister does it, 6 months later. Many similar kind of stories happen all the time.
Right. Because the downtime isn't as bad as everyone thinks it is.
Well, yeah. So, right.
And the results, of course, are amazing.
Right. So, I mean, I like to tell people the good thing about the eyelids is that there's a really good blood supply, so it heals way better than other parts of the body. Yeah. The bad part is there's a really good blood supply, so it tends to bruise more than other parts of the body. That goes away after 2 weeks.
For sure. A bruise is always worth it, in my opinion.
Yeah, right.
Okay, so let's talk about the celebrity or why blepharoplasties, brow lifts, the eye area in general has blown up. I almost feel like it's replaced the blow up of the lips, pun intended, maybe, right? Because now people are dissolving their lip filler. They're going more natural. It was all about the lips for so long. Then it was all about the cheeks. And, now it's all about the eyes. So why do you think more and more people, what's caused that? And I'd love to hear your opinion.
Cameras. I think high quality cameras. Yeah. So often I'll see patients who say, I saw a picture of myself. I couldn't believe it. And, 10 years ago, the cameras weren't that good. People didn't have like high quality pictures of themselves. I don't think they were looking that close. Now people are zooming in and they can see like every cell on their eyelid.
Right.
And they're like, wow, look at that second line on there and this and that. I also think like with COVID and Zoom, so many people who didn't really look in the mirror that often spend time on, these video calls, and they're looking at themselves and they're like, thinking to themselves, I don't think the thing that what I'm seeing in this image isn't how I see myself.
Right.
And I want to do something about it, and when it comes to doing something about it, it's relatively straightforward compared to a lot of other things out there,
Surgical interventions.
Right. A lot of other surgical interventions.
Sure.
Non-surgical is, obviously a great way to start if you're interested and you don't want to, I always like to tell people like, why don't you try climbing up the ladder, start with like the basic stuff, get, buy some sunscreen, make sure you're not like, getting skin cancer because you don't want to do anything. You want to protect your skin, take care of yourself, stay hydrated, eat healthy, do those things. And then, try some tox, try some, filler, enhance whatever you can.
Yes.
And I find that like results are better in patients who do take care of themselves more.
Sure.
Because the ones who, for example, don't, on the other end of the spectrum, if you have somebody with really bad sleep apnea that doesn't use their CPAP and they sleep on their side and they're constantly rubbing their eyelid, those cases, that's classically going to not turn out well.
What kind of things do you recommend for your younger patients who aren't ready for a surgical intervention that go beyond just the general sunscreen?
So for people who aren't ready for a surgical intervention, who like are bothered by their upper eyelids or lower eyelids or
all of the above.
Tell me. Okay. I mean, one of the easiest things is like Upneek, for example. There's an eye drop for.
We love Upneek.
I mean, I mean, for people with ptosis, it's great because it can lift the eyelid up like a millimeter or two. It basically works on the Mueller's muscle, which is the fight or flight response. It's a smooth muscle in the back of the eyelid. It just pops it open for 8 hours. Yeah. And looks nice. You can see more of your eye.
So for our listeners who don't totally understand, ptosis is when your one eyelid, sometimes both, sits a little bit lower than over the iris of the color of the eye. And so your eyelids look a little bit droopy. And so Upneek is an eye drop, which I believe I'm saying this is not fake. It is the same medication as Afrin.
Yeah, that's right. Yeah.
So don't put Afrin in your eye, but I believe it's the same medication, and you can put
different concentration. Yes.
Like 2 drops in the eye, and it works for about 8 hours.
Yeah, exactly. And with ptosis, there's a lot of different causes to it. Yeah. So it is important to see somebody and figure that out ahead of time. You don't want to, if you have a droopy, like one eyelid, it could be Horner syndrome or some neurologic thing. And it's important to like get a basic evaluation by an eye doctor just to figure out that it's not something neurologic before you like jump into the Upneek. But I think Upneek is a great treatment for people with ptosis. And the other thing I want to say about it is that true ptosis means the eyelid is like touching the pupil, as you mentioned. A lot of people have mild asymmetries, which is also another good treatment option for those mild asymmetries. So if like one eyelid's like a tiny bit lower than the other one, Upneek can kind of even it out better than a surgery even sometimes, because surgery we only have like about a millimeter room for error. And a lot of times patients notice an asymmetry that's even smaller than that. And so Upneek can be a good option.
I have some patients with ptosis of one eye, and we have Upneek at the Fitz. Yeah. But we also, I also inject Botox.
Right.
And that's a better, longer term answer for the ptosis.
Right.
So it's a nice tool in our toolbox to use.
Yeah.
Of course.
Right. And why are young people getting it? Sometimes it can be contact lenses, like
really?
a rigid contact lens especially, but soft contact lenses, putting them in and out.
Will cause ptosis?
Yeah.
Huh. I didn't
Yeah.
know that. Good thing I don't
Yeah.
wear contacts.
I'm just saying it's a good idea to figure it out because sometimes it's treatable.
Yeah. So like I said, I had a bleph at 34 years old. I had upper bleph, not lower. Should I anticipate getting a revision down the line?
Well, good question. So I think a revision can be needed or possible for many years afterwards. So it could be, I've had patients who, needed a revision at like 10 years because their eyelid skin was like sagging and really bothering them again.
Mm-hmm.
I've had other ones who had a blepharoplasty, in their 30s and it worked out fine until their 60s or 70s. And people ask me like, what makes it last longer or less long? And I tell them it's kind of like, getting a new car. If you change the oil and take good care of it,
Mm-hmm.
it's going to last a really long time. Also depends on the make and model, genetics. But things that make it last less time are things like rubbing or like chronic allergies or, stretching of the skin, which can happen from if you're getting swollen a lot. I don't know. Sometimes people get swollen for various reasons. Maybe it's allergies. Maybe it's whatever. Filler migration, I guess.
Sure. Let's talk about that.
Yeah.
Thoughts on, aesthetics in general.
Yeah.
We loved tear-trough filler
Mm-hmm.
for years
Mm-hmm.
until we didn't.
Yeah.
And now nobody likes tear-trough filler.
Yeah.
What are your thoughts on it? What have you seen? Have you seen any complications from it?
Mm-hmm. Great question. I was giving a talk at the Masters of Blepharoplasty Symposium in Sydney, Australia, and one of the speakers asked the audience to raise their hand. It was all, expert oculoplastic surgeons,
Mm-hmm.
and they said, how many of you do tear-trough filler? And it was like 10%.
Yeah.
But
But I bet 5 years before, everybody would have been raising their hand.
Yes.
Yeah.
Yes. And the consensus of this group and of many of similar groups I've talked with is that the reason why we don't like to do it as much is because there's only like 10% of people who are really good candidates.
Absolutely.
So like younger folks with thicker skin, they can do really well with it because maybe they have like the hollow tear trough and you put a little bit of filler in there and it looks great and it can look great for years. And several have had it treated like multiple times and they're super happy with it. I've met plenty of people who are really happy with treatment like that for years and years. On the other hand, 90% of the ones that I've met said like they hated it right away and they had to have it dissolved immediately. So I think the key is identifying the right person for that treatment.
Right.
Right.
And the discussion with the patient of, hey, this might look great or this will look great for 9 months, but in such a highly mobile area and with a water-loving product like hyaluronic acid filler, it can redistribute, migrate, whatever you want to call it, over time, especially if someone's got allergies or constantly rubbing or whatever.
Right, eczema or whatever. So many periorbital dermatitis, which happens a lot from like hair dyes and stuff like that.
Sure.
So many like medical reasons. Let me tell you something.
Oh, tell me.
I operated on a lady a month or two ago who was a yoga instructor and had never had filler to her upper eyelid at all. But upper eyelid. Now, but she had filler to her lower eyelid and does lots of inversions. And when we did her upper bleph, there was a bunch of filler in there.
No way.
Seriously.
How much time was she spending upside down?
Apparently enough.
That's crazy.
Yeah.
And did you notice that once you got into the surgery that that upper bleph fullness was actually related more to the filler than maybe her
We suspected
laxity?
it. Yeah. We kind of suspected it ahead of time.
Yeah.
But I thought it was really interesting.
Very.
Especially because when I did the consultation with her, I thought about it and I was like, do you spend time upside down? She's like, I'm actually a yoga instructor. I'm like, I bet
She's
you
like,
spend
I'm
some
in
time
downward
upside
dog
down.
every day. That's crazy. I've never heard of that, but
Yeah.
it does absolutely make sense.
Yeah.
And yeah, it just underscores that filler does redistribute over time and very much related to our lifestyle.
Right.
I want to know your thoughts on non-surgical, maybe energy devices and non-surgical interventions for someone who maybe doesn't have the funds for a surgical intervention, maybe not ready for surgical intervention. What are your thoughts? Things like soft wave or lasers or Botox brow lifts.
Yeah. I love energy devices. I'm a huge fan of lasers. I think microneedling and RF are both good options. It all depends on what's the exact, problem we're trying to treat.
Yeah.
So, the thing that I love CO2 laser for the most is fine lines and wrinkles around the eyes.
Yeah.
It really tightens skin, and I don't think there's a lot of, devices out there that sell themselves as tightening, but I can say for sure, CO2 laser resurfacing and strong erbium laser does, tighten skin, especially around the eyes.
Yeah. And you do that alone or?
We do it a lot of times in combination.
With the surgery.
Yeah. Well, so one other point that I would make is regarding eyelid surgery, I feel like so much of it's synergistic. So, when I do a lower blepharoplasty, we did one this morning, almost always combine it with like fat grafting, for example. That can help improve skin texture and tone. Another thing is, CO2 laser resurfacing helps a ton with skin texture and tone. I remember one of the first patients I did surgery for out of fellowship, must have been like almost 15 years ago now. I did this beautiful lower blepharoplasty, but I didn't do any like chemical peels or laser resurfacing or anything. Right. And his main complaint was like, the skin looks like darker. And what can happen is, with surgery, it causes inflammation. So their inflammation also and heat can cause skin to change pigment and change, so you get like darker skin, and that may go away with time, but I really like to combine treatments to give like a good synergistic effect. And I wouldn't discount like chemical peels. They have a role too, especially in higher Fitzpatrick patients.
Okay. Is there a type of chemical peel that you prefer?
I mean, I like doing the TCA chemical peels.
I had a feeling you were going to say that.
Yeah. I mean, there's different percentages, but it's safe. It's like very safe.
Yes. Especially in the higher fits. Yeah.
Yeah. Right. And then, they're more intense, like phenol peels, but that's like almost more intense than a laser. And we get really good results with lasers.
What are your thoughts on eye creams?
Well, okay.
Because I have thoughts. But I'm not an oculoplastic surgeon, so I'd love to hear your thoughts, and I'm hoping they align with mine.
Well, so here, I'll tell you what I think about eye cream, but I have to put it into like a space of like, what do I think about skincare?
Okay.
So what do I think about skincare? I think that's going to make a difference, like 10 to 20%. It's not going to make like a non-surgical treatment like Botox or fillers. It's not going to do a surgical difference, but it's going to do 10 to 20% of a difference in how your skin looks. And that includes sunscreens, retinols, moisturizers, vitamin C, all that stuff.
Sure.
Now, when it comes to like, face creams, a lot of them, like the most effective ones like retinol, you don't really want to put on your eyelids, right? So the active ingredients in a lot of the full face creams are too intense to use around the eyes. And when I do laser treatments, we use different settings for around the eyes than other parts. I'm getting to the short answer.
Well, the skin around our eyes is the thinnest on our body.
It's the thinnest skin on the body, yes.
So we have to be very cautious about what we're putting on it and how it's reacting, and also stressing it in a very, because every active is stressing the skin somehow, right?
Right.
And so stressing the thinnest skin on our body, is we have to do it in a controlled manner compared to the rest of our skin. Right.
Yes. Being the thinnest skin in the body, there's actually no subcutaneous fat layer.
Right.
It's just skin and then muscle. So part of the problem with dark circles is that skin can be so thin that it's transparent and you're literally looking at the muscle because the skin, you're seeing right through it like a window. So the reason I think eye creams shouldn't just be thrown away and forget about them is that I think a lot of people do their treatments on their whole face, including sunscreens and whatever, but they just totally ignore the eyelids. And so I think in patients who are like predisposed to do something like that, I think using an eye cream that has like a lower percentage of retinoid, or like maybe it has some kojic acid to brighten, or some niacinamide or some vitamin C or something like that, and they feel more comfortable putting something around their eyes that's designed for the eyes, I think in those cases, totally fine. I just put less retinol on my eyelids and don't bother with the eye cream. But I think that, to each their own. And it's like Coke and Pepsi. So.
Well, yes. And.
What you do? So you put like less retinol on your eyelids?
I do exactly what you do. Everything I put on my face, I put on my eyelids, under eyes. Right. I work it all the way up. But I'm just more careful with it.
Right.
So I don't personally feel the need to purchase a eye-specific product.
Yeah.
And oftentimes I advise my patients to do the same.
Yeah.
Because a lot of the products are really expensive. And so,
right.
If there's a $150 eye cream, but you have all the other products.
Well, and then back to the original point that I tried to make is it's going to get you 10 to 20%. It's not like a huge difference, but I think the best thing is to do what you and I do, which is put sunscreen on your eyelids, put everything else, be careful.
Let's talk about hyperpigmentation or darkening under the eyes, because a lot of people have that. And it's a big concern, but it's multifactorial. There's a lot of different causes to it. Sometimes it's actually the pigment of the skin. Right. Especially in the higher Fitz types, the darker, when I say like higher Indian, Fitz, you can have actual discoloration of the skin, or like you said, in the periorbital area, it's skin, muscle, bone, as opposed to everywhere else where it's skin, fat, muscle, fat, bone, right? So when you have that translucency or transparency of the skin, what types of non-surgical interventions do you recommend to make that translucency of the skin less so it's helping that pigment? Now, I think that is why everybody loved filler so much, because it was creating more of a buffer between the skin and the muscle, so it brightened the area.
Right.
But like we already discussed, not always the best long-term solution. But do you have any suggestions for both of those concerns, pigment and the translucency?
Well, so the pigment, the best thing is kind of bleaching agents, right? Yeah. And avoiding like building more pigment, which happens with ultraviolet light, so sunscreen, and wearing sunglasses. In terms of like the thinness of the skin, one of the best things you can do is CO2 laser, because that lays down more collagen, thickens the skin. If you're not ready for like a really intense like CO2 laser, you could try like microneedling. That can build some collagen too. It's going to take longer and you're going to need to do more treatments.
Let's talk about, I'll give you two options to talk.
Okay.
Do you want to talk about Ozempic or do you want to talk about Bradley Cooper? Which one first?
Let's talk about Bradley Cooper.
Let's talk about Bradley Cooper. Bradley Cooper has recently come out and denied any surgical intervention on the Smart List podcast. I look at him now, and I do feel like he looks different than he did a year ago, or maybe 2 years ago. What are your thoughts, especially around the eyes?
Yeah, well, I mean, to me, he looks different than he did before.
Yeah.
Too. I mean, I think everybody, almost everybody feels that way. And when I look closely, because I've looked at several images side by side.
Yes.
One of the things that I see is that it looks like it's hollow above his eyelid, which, one of the things that has been a trend in oculoplastics in my field is to remove less tissues. So one thing that can make you look more hollow is to remove like fat and skin and muscle. And one of the things that you mentioned is like, how do you preserve the person's appearance without causing any harm? One of the ways is just to remove skin. So at upper blepharoplasty, we can just remove the skin. But it looks to me like he had a lot of fat sculpting behind his upper eyelid. The other possibility is he may have had a brow lift or both.
I see him and I wonder if, sexual dimorphism is very important when it comes to preserving someone's appearance. And of course, as I approach a face, I'm never trying to feminize a male or masculinize a female, especially around the eyes.
To me, it looks like his eye shape changed a little bit. So when you look at your upper eyelid, like where it rests against your iris or pupil, generally the peak of the eyelid is just medial to the pupil. So just slightly medial to the pupil. That's where it should be at its highest arch. But if you look at Bradley Cooper now, his peak of his eyelid is a little bit lateral to the pupil, which tells me he may have had a type of ptosis repair, like a droopy eyelid repair to tighten the muscle to like open up the eye more, which is a lot trickier surgery, but it gives you also the risk of changing the eye shape, which is patients tell me all the time, I just don't want to change my eye shape. But I do wonder in Bradley if he had a ptosis repair by somebody who maybe wasn't the most expert ptosis surgeon. Because it also looks like he had some jawline stuff done. So I'm guessing it wasn't actually an oculoplastic surgeon who did his work, because most of us don't do that, although some do.
I think when bad filler, bad surgery results are in the media, it scares a lot of people.
Yeah.
And so with the discussion about Bradley Cooper and other celebrities out there in general, if someone gets a bleph that might be too aggressive or too much, is there a way to repair that?
Yeah, there are always things that can be done and considered. But just like the initial discussion, we have to weigh the risks and benefits. So sometimes the benefits are so little that it's not worth taking the risk. Other times, especially when there's like a disfiguring like botch job, then it can really be worth it. I mean, if someone comes into me from another surgeon and their eyelid's hanging down to their cheek, I'm not going to tell them like, sorry, risks outweigh the benefits. Like you just have to live with it like this. No. I would never do that. Right. I'm going to take that person under my wing and try to help them, even though I know it's going to be really hard. It's not going to be an easy journey. I'm going to try to help them. On the other hand,
let me stop you right there.
Yeah.
When I told people I was bringing you on this podcast, some of the responses that I got about you were, he really takes care of his patients.
Oh, that's sweet.
Just so you know, that's what the people are saying about you behind your back.
Okay, great. Yeah, well, I have a heart for people. I want to help them the best I can. To me, it's not just like a cliche that I am treating them like family. I really am trying to do that.
Yeah.
I will say, though, that there are a lot of times when somebody wants like a revision or like a touch up and they're really bothered by something that I can see it, but like what we can do about it is like a pretty big step to like fix it. And a lot of times in a situation like that, I'll say, maybe let's give it some time. We can always do a revision or a touch up in 6 months or a year. But right now, doing that, it's probably not worth it. It's a lot of times more worth it when you can do something else to also enhance their appearance. Like maybe in a year or two, they could use like an eyelid bag surgery, or they could use something else, and then touching it up at the same time won't be as big of a deal. All
right. You ready to talk about Ozempic?
Sure.
So I don't know if you know this. My husband's an OBGYN.
No, I didn't know that.
He recently has been enlightened by some articles talking about Ozempic vulva.
Oh, okay. Wow.
And it is basically a loss of subcute fat.
Mm-hmm.
And so things are getting loose.
Okay.
Have you noticed similar trends with Ozempic eyelids?
I would say yes.
Yes?
Yes. I've had many patients come in recently
Yes.
telling me that after their massive weight loss, they've noticed bags. They said that they really didn't notice having under eye bags or other, things about their face that they didn't like.
Yeah.
Until after getting Ozempic treatment.
And what is causing that?
I think part of it is those fat pockets. So part of what shows the under eye bag is that there's what's called the SOOF, the suborbicularis oculi fat pad, that descends.
I love the SOOF.
Yeah.
Do you know that
yeah.
I love the medial and lateral SOOF? Those are my favorite deep fat pads to reinflate and support with some hyaluronic acid filler.
Yeah. It's a great thing to do there.
Love me a SOOF. Keep going.
Yeah. Well, so those are deflating and descending just with aging. And then if you're on Ozempic, it's making your body more healthy overall, but you're going to see that orbital rim a lot more because the fat has deflated, and what's been masking that orbital rim before, or that tear trough, is now gone.
And so I've also seen this in my practice.
Yeah.
And so because I'm not a surgeon, and most of my patients aren't necessarily ready for a surgical intervention, what I will do when the medial and lateral SOOF are deflating, I will actually place filler, hyaluronic acid filler, deep to replenish those fat pads. Not tear trough filler, but right in the mid face. And the medial SOOF has really actually does not need that much filler. It's called the surface volume coefficient. It does not need that much filler for a noticeable change. So oftentimes we're placing HA filler in the medial and lateral SOOF, and then even along that lateral orbital rim and very small aliquots to disguise a lot of those hills and valleys, exactly, that we're noticing with weight loss.
Right.
And it's pretty rewarding. And we're seeing patients who have lost all this weight, who have been uncomfortable in their bodies for so long, and they're losing all this weight. They feel good finally. And then on the other side of things, oftentimes a full face is a more youthful face.
Right.
And so when you lose that volume, it can, not always, can age you a bit.
Right.
Non-surgical, surgical interventions are available to patients who are wanting to invest a little bit more in their appearance and restore some of that.
Yeah. It comes up a lot for me too with fat grafting.
Yeah.
When we graft fat from the abdomen or thigh, we micronize it down, a lot of times inject it under the eye or above the eye. And, we don't want patients to be taking any GLP-1s around that time because we don't want that fat to get reabsorbed. So they have to kind of take a break from it, reach their ideal weight, prior.
Yeah. It's this whole wave of regenerative aesthetics, as you know. Sculptra, Radiesse, things, we're injecting things into our body to use our body's ways of healing and promotion of more collagen and elastin for a healthier, more youthful appearance. Now that we've trended away from tear-trough filler, we were doing more and more PRP, and then people were doing more PRF, and now there's Easy Gel out there.
Yeah.
What are your thoughts?
I think it's a great trend overall. I think using regenerative medicine sounds great. I think that there's
a butt in there. There's a big butt.
I mean, the butts are. It's not like very well regulated. You can't say 100% whatever I get for PRP from you is the same as what I get from someone else because it depends on your overall health. right?
Well, I think in general, these bioregenerative treatments, I tell all of my patients, it unlike HA filler, which is predictable
right.
and reliable, we're relying on you now, on the patient and the host. If they're not healthy, if they're binge eating McDonald's the night before, we get their blood and maybe they went on a bender and, you know, whatever, the results aren't going to be as reliable.
Yeah.
And they're not going to be as robust as maybe someone else.
Right. Exactly. So the other thing I want to say about PRP is that I think it's great. We have nurses who do a great job with it. We use a company that has great high quality PRP where it's a double spin. So you spin the blood, take the serum off, and then spin it again, and then put the platelets back into solution. And it's really a high concentrated platelet solution. I think a lot of places that do PRP, at least what I'm seeing on like social media, they're basically just like injecting plasma. They spin it one time, take the plasma off, and inject it. So there's different qualities of these things that we call PRP or PRF or whatever we're calling it. I think if you go one place and get it, it's different than going somewhere else and getting it. So I think there are a lot of people out there who've had PRP in a place that was kind of like discounted, not necessarily doing like the real stuff.
True PRP.
Yeah.
Yeah. Actually getting the platelet rich plasma.
And they also may not have like had what to expect explained to them, which is it can help with dark circles. It can help with skin texture and tone. It's not going to get rid of bags or...
And it's definitely not going to provide volume.
Right. Correct.
Right. I think that is something that people really want it to do, but it won't.
It won't. Yeah.
The only volume that it may give is the growth factors making the skin healthier and the skin actually being a bit more robust, but that's more on like a cellular level, if anything.
It's pretty minimal. Yeah. Right. So PRF, people like it more because it lasts longer, but again, it's not going to give volume for like months and years.
Right.
Right.
And we do Easy Gel, which is grabbing the PRF. We take 2 vials. One vial, we grab the PRF. The other one, we grab the albumin. We heat up the albumin, which is then kind of congeals things, making it more of a filler-like consistency, and we mix the PRF back into it. So we're injecting it, this filler-like consistency of your PRF and own blood products. So it concentrates the growth factors and the platelets in the under eye area. We've found that it gives more noticeable, more dramatic results than just the PRP alone, because the PRP is just also super thin and it just kind of spreads.
Right.
Yeah.
How long does that last?
We have patients do 2 sessions, about 6-8 weeks apart. My under eyes were done February 2025.
Did you do both or just one?
I did both, and so I've been happy with it.
Okay.
But it's also one of those things. I've had a bleph. I want to maintain the skin integrity around my eyes, and so I'm going to be doing treatments like Easy Gel, PRF, and energy-based devices. Yeah. We like soft wave. Yeah. We also do ablative and non-ablative lasers around the eye, just to make sure that I'm like maintaining my results, holding on to my skin and the quality of my skin as long as I possibly can. Yeah. So
that's great.
Yeah.
Yeah. I like soft wave too.
Yeah.
I think I've seen a lot of patients with good outcomes from it. Back in the session we were talking about earlier about radiofrequency microneedling.
Yeah.
I think that is a great example of your provider matters.
Huge.
So if you're getting radiofrequency microneedling and it's someone who's new and trying to get great results and they're doing deep treatments with high energy and they're melting your fat, that's not a good thing.
It's actually the opposite of what you want.
That's the opposite of what you want.
Right.
And that's why there's a lot of warnings on it now. So make sure you're finding a good provider.
Yeah. The machine we use is Morpheus.
Right.
I don't know.
That's what we have too. Yeah.
Okay. Morpheus is amazing of what it can do because of the range of depth that it can. And we also have body treatments as well.
Nice.
And so you can do you use the prime tip for you guys?
The small one.
Yeah. So
right.
I'm assuming because you're working around the eye.
Right. And it can work great for festoons and fluid, malar edema.
Yeah. when we're also talking about fat, we don't want to go anymore, especially around the eye area.
Right, right.
1 or 2 millimeters?
Just 1 or 2 millimeters.
Right.
Yeah, you really don't want to go deeper than that.
However, we have a lot of patients who have, the jowl fat that they don't love, nasolabial
Right.
fat that they don't
Yeah.
love, submental. And so it's a wonderful machine when in the right hands, going 1 to 2 millimeters around here, but then increasing that depth and radio frequency along the jawline because you really can kind of contour that jawline and blast that sub-Q fat and remodel it even.
Right.
All the talk about Morpheus really is based off of being in the right hands in the right provider.
Right. Yes.
All of these devices really.
Yeah. Yeah. I think the companies want to make it like idiot proof, but the trainers have to be good, and sometimes they don't necessarily. You can have a really powerful device in the wrong hands, and it can cause a lot of problems.
What is one thing you wished all patients knew before coming in to see you?
I wish that they all had a good idea of what it is that really bugs them, like why they're coming to see me.
Because taking that out or finding that thread can be difficult.
Yeah. I mean, if someone asks me my honest opinion, I'm happy to tell them exactly what I think, but I can fix this problem for that person.
Sure.
Because what I'm looking to do is like fix problems, I see these problems and they can tell me what the problem is, and I can deliver a solution. If the person comes in and is just like, what are you going to do to make me look refreshed? I can do that. I can do that too, but I don't want to, I don't want to give them any complexes or,
It's delicate.
concerns.
It's a delicate balance for sure.
Yeah. This has been a pleasure.
It's been a pleasure.
It's been an honor and a pleasure. Thank you for having me.
Thanks for coming. I really appreciate you sitting down with me. I know that Thursdays are your surgery day.
Yeah.
So
I already got a couple surgeries out of the way.
You got some surgeries out of the way. Yeah, and I know
and
it's
they
a
did great.
commitment.
So
Good.
Can't wait to see.
I hope this experience was good for you, and maybe
I gave you like everything,
I know.
all of my
Thank you.
everything I have. I left it on the
love
table.
that. And now you have to go back to your family and kids and give them more.
Yeah,
No.
no, they're great.
So, Dr. Phelps, if someone wanted to schedule a consult with you or find you on the gram, how can they do that?
The easiest way is drphelps.com, drphelps.com. That's our website. You can schedule right there. You can see what we do. And then my Instagram handle is paul.phelps.md.
Thank you for joining us for this episode of Fine Lines. You can find us at thefitzmed.com or on Instagram at thefitz. See you next time.
This show is for entertainment and education, not medical advice. If you are interested in treatment, please see your medical provider or book an appointment at the Fitz.